Thank you. Sorry, I got caught up by something and time just rushed through. But don't worry, we'll have this. It's a very wide topic, but I have tried to make it, pick up all the important things. Let me share my screen. Can you see my screen?
Yes.
I see Chepkemboy, you've raised your hand. Is it okay? Hey, today we have quorum. Today we have quorum. Well, okay. Is my screen moving?
Yes, it's moving. We're on learning objective.
Okay, fine. So let's start. Apologies again for starting late. So we start now. The topic. Again, you remember on Monday we said I was very sure I would not get to that room that we used the other day. So of course we made a consensus that we can just do it online. I have still, sorry, not talked to different authorities, although I knew it may not have a lot of impact because there's a lot of preparation for the graduation. But I am going to raise this issue and we see what at least can be done, next week or something, so that we can have sockets in the rooms. I'll ask them to tell me which room they have been allocated, and then we can see how that can be done. Okay. So we'll start. I'm going to look at the GIT pathology. I know we started that before. We've looked at the esophagus and the stomach. So today I will look at the intestines. So, and unfortunately, we've not put all the classes that need to be done. We've picked what we feel is important during the layout of this. So the part I'm going to carry out today is the appendix. Then I'll look at inflammatory bowel disease, and then look at the tumors in the GIT. Again, you'll see how I've arranged this because these are very wide topics, but I've picked what should be done. Of note is that you'll notice that I'll not discuss enterocolitis. It's not part of that what we've picked, because part of it maybe was discussed, say, in your microbiology and immunology. So it's good for you to just go and check those things of E. coli, when E. coli affects the GIT, the enterocolitis that comes from it, your salmonella enteritis, you look at that, your TB, especially in the ileum, you look at that and how it appears, your pseudomonas colitis, all those as enterocolitis, you look at them. For now, I'll just look at the appendix. I look at IBD and GIT tumors. It's a bit long, but we'll go through it. Some of it is sort of like repetition. Once you grasp the way I've arranged it, it becomes easy to, even during your own reading. Okay, so these are our learning objectives. We look at the appendix. Under the appendix, we're going to describe the etiology. We look at the mechanism, the morphology, how the patient presents, and the actual management. Then after that, we look at your ulcerative colitis and Crohn's disease and inflammatory bowel disease. Same story of pathogenesis, morphology, up to diagnosis. Then we look at the GIT tumors. So for the GIT tumors, we look at generally about them, like 3 slides. Then after that, we look at the esophagus. Then we look at the stomach. And then we look at the colon. And then that's it. Those are the ways we have arranged this lecture. So we'll start with the appendix. I'm sure all of you have heard about the appendix and somebody having, an inflamed appendix and maybe it being removed. So this is the brief thing that I want to talk about in an appendix. First of all, from your anatomy, it's usually a true diverticulum, like a true outpoaching, okay? At the cecum, when you look at when you're leaving your small intestine going all the way now from the cecum, ileum, cecum, at that level, I'll show you a photo, okay? And this diverticulum is very prone to inflammation, okay? Both acute inflammation and chronic inflammation, and we will see that. Epidemiologically, the risk of somebody in their lifetime to get appendicitis is 7%. Males are more affected than the females. Please don't ask me the reason, I don't know. We'll just speculate. Now we go to the pathogenesis. As I said, I'd like to show you a photo. I like moving with photo. Appendix is usually a small thing like this. So we usually measure the length. It's like this. Of notice that it could be located anywhere, but many times this is the usual or normal location. Okay. Now, when we are saying pathogenesis, we look at things that would cause it to have inflammation. We said it can have both acute and chronic. So now this appendix of ours, this one, the lumen, when you cut it and now you're seeing the inside of it when it gets inflamed, which is like this. What usually happens is that inside here, you can have things obstructing. For example, a fecolith, like stool, it has stayed there for some time. You can get it coming and getting trapped inside this area. You can have on the wall of the appendix, we usually have, it's just like the wall of the whole GIT. So have your mucosa, submucosa, muscular layer, and then serosa. Now, we may have a lot of lymphoid. There's a lot of lymphoid in the submucosa. So you may have hyperplasia of the lymphoid that becomes so big and obstructs the lumen of the appendix. I see that a bit also during my, when patients have brought the appendix, or rather the surgeon has brought the appendix for me to evaluate histopathologically. Then you may have a tumor, and I'll talk about the commonest tumor that we see in the appendix before the end of the lesson. Okay? And other things, you could even have obstruction by worms, by the way, Can have even worms coming in here and obstructing this area. I hope you can see my cursor, the arrow that I'm showing with here. So when those things come here and they cause this lumen obstruction, what will they do? They'll cause bacteria to grow. Remember, there's, of course, bacteria that is roaming in your GIT, okay? The enteromicrobes, okay? So the bacteria now, because there's obstruction, they'll accumulate and grow. And by so doing, and on top of the fact that there's obstruction, there will be increased pressure inside this tube, this one here. There'll be increased pressure. Now, when you have increased pressure, you many of times compromise the blood supply. So because of compromising the blood supply, you end up having ischemia in this appendix. Okay, it's should. So you have ischemia. So when you have ischemia, what happens? No blood supply, you have cell death, you have inflammation fast, because of lack of the blood supply. Some of the cells may die. You have inflammation from bacteria, you're trying to fight that. So you end up having the appendicitis, the inflammation. Sometimes it may become so bad that you can perforate it. Okay, you may have a hole. A perforation is just a hole in this. So like this wall like this, then you have a hole somewhere here. So when you have a hole, the contents which are inside this lumen, the fecally, the inflammation, the pus that has formed, leaks out of the appendix and comes to the peritoneum around here. Okay, so we end up having a periappendicular peritonitis, okay, or formation of an abscess also around that area. So that's how it happens. So you have your normal appendix here in this picture. You look at the mucosal layer, you have very nice cells here lining. But now when it gets inflamed, you have your inflammatory cells, you see, your neutrophils coming in, your macrophages, which release cytokines and chemical mediators causing the inflammation. That is how you get it. So complications is that it can perforate, as you can see here. Then the contents get out and go to the peritoneum. Okay. So this is a summary of this part. Progressive increase in intraluminal pressure, which will compromise the blood flow. Okay. And this is because of the luminal obstruction. Then inflammation is triggered. Okay. So we move now and check. So if you have this appendix inflamed here like this, okay, so remember the cardinal features of inflammation. There is swelling, as you can see here. It gets swollen, it becomes red, okay, it will cause pain, and that is what I'm coming to. That now the patient is going to present with pain. And remember, the appendix, we've said there it is an output near the cecum. So it is usually on the right iliac fossa. So when the patient comes, they will present with pain in the right iliac fossa. In fact, when you examine around there, you have something we call a positive McBurney's sign. Okay, so that's how they will present, and I show you that as the clinical presentation. Okay, the periumbilical pain, okay, in the right iliac fossa. It can be because of nerves. It can come around the umbilicus. So the right iliac fossa, reef is right iliac fossa pain, then periumbilical pain. Okay, then it can radiate around the umbilicus. Then they may present with nausea, vomiting, and that some low-grade fever. And if you're to do a white blood cell count or a CBC, you'll find a bit of the white blood cells, especially in the neutrophils, being elevated. Okay, when you examine the abdomen, you'll see that McBurney sign pain around the iliac fossa. Okay, okay, so that's how they will present. But how do you see it? That appendix, if it's brought to me, how do I see it? Okay, so grossly, it's going to be a very dull, granular appendix, okay, with pus, fibropurulent exudate on the cover and sometimes ulceration. And then when we cut this area, here you cut, inside here, we see the fecalith, okay? If there was a fecalith there, this is some material which looks like stones inside there. Okay. Then microscopically, because it said it's acute inflammation, we'll see neutrophils transmural all the way from the mucosa, submucosa, muscularis propria, and up to the serosa. So the minute, that's a hallmark. The minute you see neutrophils, transmural neutrophils, all the way to the muscularis propria, the muscle layer, then you know you have appendicitis. Okay, and sometimes they may have an abscess. So this is our nice appendix. You see, grossly it's swollen. I mean, it's appendicitis, so features of inflammation. Okay. See, it's grossly swollen. Okay, you can see glistering, like shiny. Okay, as you can see it there. Okay, so it has been removed. This is in theater, they have just removed it, it's a fresh one. So when it comes to my desk, I'm going to cut it. So usually in my grossing, I'll gross across like this, transverse one, another one, two. Then from here, like this, all the way, I'll cut it the way you're seeing it here. You cut longitudinally, like this. The reason for that is because at this tip, many times you'll see the fecalith, you may see the worms, but of most important, it usually likes staying here at this tip. So you will catch it when you cut like this. Okay. This is another appendix. This one has the pus. You can see purulent exudate, as I've put here. Purulent is pus. We did that in acute inflammation. Here like this, covering. Okay, similar to that. So that is gross with the eyes when it has been removed. Microscopy, I said neutrophils, and I want to show you. So now when you've cut this area, then you've put it under the microscope, and that's what I'm seeing. This is what I see. So this is the mucosa. Mucosa is in the lumen, the lumen. Okay, mucosa is in the lumen. So what you see here, this is mucosa inside, like this. Then here you can see inflammation, but of note is the small black dots. They have come all the way to the muscular layer. This is muscle. You go back to anatomy. The GIT, including your appendix, is made up of mucosa, submucosa, muscular layer, then serosa. So I'm saying for you to say there's appendicitis, then you will see the neutrophils all the way even to the muscular layer. And that's what I'm demonstrating here. The muscularis propria. So these two small dots that you're seeing, they've come past this layer. This is muscle. This is mucosa. Some of it is ulcerated. As you can see, it's lost here. There's no mucosa. Then all this is inflammation in the submucosa, which moves all the way to the muscle and a bit to the serosa, which is after that. That's a hallmark of appendicitis. So we've talked about the features, how they'll present, and these are some of the differential diagnosis. What do I mean by differential diagnosis? If you have a patient who presents with right iliac fossa pain, what are the many things that could be underlying that pain? For example, if it's a female on the right side, you look at the organs which are there. It's not just the appendix. We may have the tubes, fallopian tube. It could be an inflammation of the fallopian tube. So it could be acute salpingitis. So you have to have all those thoughts in your mind. It could be an ectopic tubal pregnancy. It could be pain that usually is experienced. We call that metal kisman. Mas. When you're having, when the lady is having menses, or I mean, during that time of ovulation, a bit of bleeding may occur and cause some slight pain. So that could also be the reason why they are presenting. Or it could be the actual Meckel diverticulitis, or it could just be some lymphadenitis in the mesentery around the right iliac fossa. So you have to have this in mind as the other reason that they're having this kind of pain. Okay, of course, acute appendicitis will be top on your list. Okay, then these are the other differentials. I have only mentioned, I think, 5. The list could be longer for the differentials. I'll send you to go and read about it. Okay, to add, not read, add on the list because I have given you some. Okay, so what complications can we get? As I said earlier, you can get perforation. You can also get phlebitis. That's just inflammation of the portal vein. Okay, okay, and then you may get bacteremia. Okay, sepsis can affect peritonitis, then sepsis that spread to other parts of the body. The mode of treatment for acute appendicitis is to remove that appendix. So appendicectomy. Okay, so what are we saying here? We remove this. It gets inflamed like this, can get perforated, cause peritonitis here. The bacteria can spread to the whole body system, we call sepsis. Management, you just come and cut it. You just come and poop, remove it. And bring it to me like this. And you continue surviving. So that's management. Okay. And I have finished with appendicitis. I suppose there and ask questions for the appendix. Can you hear me? Yes, Julius or Timothy A?
Yes, we can hear you.
Okay. Any questions on the appendix? I have even managed it. I have told you we usually remove. No question. So we move to the next one. Okay. So as I said, those are the main things I was supposed to cover. So we will move next to inflammatory bowel disease. Oh, I didn't do the carcinoid tumors. Okay, fine. Before that, I changed this last minute. You know the way I'm going to do GIT tumors, I'll have done the ones of the appendix at that level, but I decided to do the appendix and finish plus the tumors of the appendix here. It's only 3 slides. So the appendix, as I said, around this area, the tip here, this area, this is the tip. Many times we'll have tumors, and the commonest tumor is a carcinoid. And that's the reason why I said we usually cut it like this so that I pick the tumor here, which is a carcinoid tumor. Okay? So carcinoid is the commonest tumor of the appendix. And as you see, it's a neuroendocrine tumor. So it's coming from the enterochromaffin cells. So it's coming from the which are that are in the appendix. So that's it will arise at the distal tip, as I showed you earlier, and usually when it's formed, it's a mass, it's tumor, so it's a growth, and it will produce a solid bulbular swelling, usually about 2 to 3 centimeters. Okay. Of note is that carcinoids are slow growing, and it's slow growing. It has a very low potential for spreading. The high grade, unless it's a high grade one, and especially when it's less than 1 centimeter. Okay, so yeah, metastasis is rare. Okay, so this is the bulbulous swelling I'm talking about. You see, this is the appendix. Now I've cut across. This one here, we've cut here. You know the way I said you cut here, then after you cut here is when you'll cut around now like this longitudinal. So this one that we are seeing here, we've cut it like this. So you're seeing here, this tan white swelling inside the lumen, which has blocked the whole lumen, is your carcinoid. Okay, so it's usually small, firm yellow tan in color nodule that you can see here. Then when you cut this now and put under the microscope, this is what we see. This is an H&E stain. So you see very well. So this is the mucosa. So you see the mucosa here nicely like this. Then within the mucosa and in the submucosa, you see these cells which are arranged in nests. Okay, nests. You see, like this is one nest like this, or here you can see this is a nest. No nests like the ones for a bird in the tree. So nests, sometimes we call this organoid. Looks like an organoid. Okay, and the trabeculae, some of them are in strips. Okay, like this. So we see that. Okay, and then on high note, they will have on a higher power, as you can see here, they're small cells with very scanty cytoplasm, and they form, see, very small scanty cytoplasm, and they have a salt and pepper like chromatin, just the same way I talked about the neuroendocrine tumors in the lung. They appear the same way. And then because it's a neuroendocrine, it will be positive for neuroendocrine markers. So for this one, usually we do chromagrinin A and eosinophilin, which will be positive, as I have put here. Okay, I haven't shown you photos of IHC showing that. I just mentioned. So that's how your carcinoid is. I actually reported a carcinoid yesterday. Yeah. And this one, it was after gastrectomy, because this one was humongous. It was actually a neuroendocrine high-grade tumor. This is how it was in the stomach. It was not in the appendix. It was a high-grade type, okay, with numerous mitosis. It had really spread, and yeah, even in the nodes. Yeah, we call that, ours was a high-grade neuroendocrine tumor yesterday. And then there's one I reported, I think 2 weeks before, which was in the colon, not appendix. Yeah. Okay. Another thing that we can get in the appendix is a mucocele, and there's a reason why I have reported that, just from the name is mucus. Mucus. So this one usually is a dilated appendix which is filled with mucin, mucocele, mucin, and may simply represent an obstructed appendix which has mucus that is tucked inside there. Okay, as just a mucocele. However, it may also be cystadenoma. Okay, you see the difference. Adenoma is benign, cystadenocarcinoma is malignant. Okay, through the wall. Okay, it's carcinoma, so it will invade. Okay, and then through the wall of the appendix and gets into the peritoneum. Then it starts seeding. Okay, like they used to say about spreading or metastasis of tumors. Okay. In women, you have to be very careful not to mistake it for mucinous ovarian carcinoma. Okay, we'll discuss that next in January. Okay, so in most instances, the abdomen is filled with this mucin. I show you a photo. We usually call that pseudomyxoma peritoneae. I've reported a couple of those, and because the first time I didn't know what it was, when I reported, and I was qualified. After I reported, I mean, I had read about it, we'd been taught in school. So, and I reported it during, the first year when you're still under someone. I was very excited after I was shown, and then now I could report by myself very many. So this is anyway how you see it. This is in theater. It is a retractor. So you're seeing the mucus jelly-like in the peritoneum here. That's what we call pseudomyxoma peritonei. Okay, you see this fluid here, very gelatinous. Okay, then when you take this and look at it under the microscope, this is what you see. So a lake of cells. This floating pseudomyxoma peritonei. Yeah, this is how they see it on CT scan, and then in theater we see this gelatinous thing. All this which is brought to my table, and I look at it and give them as this report and call it your fix. So next time you hear somebody saying that, again, as I said, in females, we're usually very careful. We have to look at the. We are done with that part. So we've looked at inflammation of the appendix and the common tumors in the appendix, which is bad. So now I move to inflammatory bowel disease. I pause there first and ask anybody who's had a patient with inflammatory bowel disease or any prior knowledge that you know about, talk, or you can type in the chat box. Only 1 minute. Any story, anything, you don't Google. Imagine I'm now in class. We are there in that room that we had found last time. We're just sharing. I'm gonna teach. So you don't Google, just say what you know. Then we're going to, if it's a myth, we're going to correct it. If it's an experience you've had, we're going to talk about it. Anything, anyone? Nothing. Okay, fine. Let me then just teach. Okay. Are you still there?
Yes.
Pascal, okay, thank you. Thank you, Faith. Now now you're all quiet, and I see we have quorum, but maybe you've not heard of inflammatory. Let me just teach you about it then. I mean, the other time you were engaging so much. No, maybe you're waiting for those main topics. Okay, let's look at inflammatory bowel disease. We call it idiopathic, and I'll explain why. Like we really don't know the mechanism, but we have hypothesis for it. Okay, so IBD or inflammatory bowel disease is really a set of chronic inflammatory conditions which are coming from inappropriate and unregulated persistent activation of the mucosal immune system. We have two main diseases under this category that we're going to discuss today, which is Crohn's disease, and the other one is ulcerative colitis. Okay, they have similar things, but we'll look at each and then look at about it as we run through the course. So as I said, it's chronic and relapsing. Okay, the origin is very obscure, but postulations say that there's unregulation and exaggerated immune response in the GIT to the microbes, both of those who are commensals, okay, the microorganisms which are commensals in the gut, okay, and of course, it will happen more in the people who are genetically susceptible, so there's no balance, okay. So we look at that. So I just put this for us to remember that normally in the intestine, there's a steady physiological inflammation. We could put that steady state, okay? Physiological inflammation. What do I mean by that? There's a balance. That's what I should say. There's really a balance, okay, which really has to be maintained. Because generally, we are eating, we are being exposed to things. So there are factors that, from the food we eat, or even the microbes that are in our the bacterial microflora that we already have. Those are things that would easily initiate our bodies to react, the immune process to react and start inflammation. Okay. So there are factors that activate the host immune system, like the things in the lumen, like microbes, what we have eaten, like dietary antigens, or even other endogenous things that are within us that can cause inflammation. Then on the other side, we as the hosts, we have defense mechanisms that will down-regulate that inflammation and maintain that integrity of the mucosa. So usually, because these are things going on, we have to maintain this balance. Okay, that's what I'm calling a steady state, a steady physiological inflammation. You're not exaggerating this inflammation. Okay, so that's what we do. So for the inflammatory bowel disease, this balance is what is affected. So people don't have this balance. Okay. So those microbes or antigens that you've gotten in, they cause an inflammation and our body is not able to downregulate. Okay. So for those who are genetically susceptible, so the failure of immune regulation. Okay. And then the microbes which are already there, then they trigger now an exaggerated immune response. And that's how you have these people having a chronic relapsing inflammatory disorder. That's the story behind it. Of course, we look at the genetical, which are these genes that make them to be predisposed. Okay. But that, in a nutshell, that's the reason. We are now affecting our normal physiological inflammatory state. Okay. That we usually have. So we exaggerate on inflammation for this. Okay. So we'll start with Crohn's disease. Okay. So for the Crohn's disease, a bit of epidemiology. It's, as we said, it's a chronic relapsing inflammatory bowel disease. Its incidence is ranging from 5 to 10 per 100,000. This is from the US and Europe. In our country, I have never even seen a Crohn's disease patient. It's not that much. I mean, I see a bit of ulcerative colitis compared to Crohn's. I remember one time my gastro, sometimes I sit and do endoscopies with her when I'm bored. So we are sitting there, we have seen, and she's so excited. She tells me, look at this, look at how it looks. I tend to think this is Crohn's disease and everything. And so we take biopsies. I look at it, I don't see anything, like points to Crohn's disease and all. And I tell her, by the way, I look at it, but I also share with my colleagues. And of course, from the history and everything, we're all excited. And so a couple of us look at it and we're not seeing anything. And it was quite disappointing because we had all said, oh my goodness, we are going to have our first Crohn's disease. But yeah, it wasn't. I don't know, but generally myself, I haven't seen one. And another colleague who I do a lot of GIT with, who is my close friend, in one of the big hospitals, also had not seen one. But it could be there, but it's rare in our locality. So it's more common in young adults from 20 to 35 years, the peak, when we see peak, then they'll keep on having those relapses. So you'll have it continuing, okay? Females are more affected than males, okay? As I said earlier, it's more in Northern Europe, in the US, and the US, mainly the people who have of Jewish descent are the ones affected more. It's rare in Africa and in Asia. It's quite rare. Again, it's more in whites than it is in blacks, okay? But now the incidence is increasing worldwide, okay? Of note that smoking is strongly associated. I think it also activates the immune process. Okay, smoking, as we said earlier. So we look at etiology and the risk factors, just as we had mentioned earlier. And as I said, it's multifactorial. Okay, many things are involved, many factors are involved. Genetics, as I said, is very important. Then the immune dysregulation, other environmental factors, and the intestinal microbes. Okay. So genetics for Crohn's, it has a strong genetic component compared with ulcerative colitis. And of note is the gene, the NOD2, or what is now being called CAD15. Patients with Crohn's disease, we found this gene with them, the NOD2 or the CAD15. And they also have
positive family history, okay, very strong, like one relative and the other relatives having it. So we see there's a genetic leakage. And then they also have associated with the MHC complex, the HLA, DR7, and DQ4 alleles. So you can see there's a genetic predisposition, which will make that steady state to be affected. Okay. Immunologically now, we have abnormal activation of your innate and adaptive immunity. Okay. One of the reasons is that the genetics that have been acquired, that the patient has, the genes, they have, like, for example, a mutant form of interleukin 23 receptor. Okay. So this mutated interleukin 3 receptor usually works on the TLPA1 and TLPA17 and activates them to keep on now forming that exaggerated chronic inflammation. Okay, so these are cytokines. So they activate the inflammatory system. But it's because of the mutated interleukin 23 receptor as one of the reasons. So there's an excessive inflammation from your T helper 1 and T helper 17. Okay, this is mainly from your CD4 cells. So many times for the inflammatory bowel disease, it's from your T cells that we're having this occurring. Okay. Environmental factors, we said smoking is a major thing, and also diet, especially diet high in fat or those processed foods. And as I said, it's now coming home because now we are eating a lot of this processed high fat diet in our country also. So we might change the incidence by having that. Okay. So that's a bit of etiology and the risk factors. So for the pathogenesis, so we already have a genetically susceptible individual with either that node 2, okay? Then the gut barrier gets dysfunction. How? Because there'll be a chronic inflammation from the interleukin 17 and the interleukin and the T1, T helper 1 cells. Okay, so you have the T cells mediated inflammatory reaction, and you're not able to control it because genetically now you're having this being uncontrolled, being unregulated because of the mutant part. Okay, so the immune response overreacts to the bacteria which is in the gut. And remember, this was like no more commensals in the gut. You're not seeing it as normal. You're just clearing, bringing inflammation, exaggerating it. Okay. So that's how you end up having inflammation, chronic inflammation, where we have granuloma formation. And remember, these granulomas are not caseating like TB. They have no caseous necrosis like TB. We'll have ulceration because of continuous inflammation. We may have healing with fibrosis where we form strictures, okay, in these patients, and even fistulas, connections between one epithelium to another epithelium, or sinus tract, where you come out, even you can come out into the skin as a sinus tract, okay? So that's usually what happens with Crohn's disease. Of note is it can occur in any part of the gastrointestinal tract, from the mouth to the anus, from the mouth to the anus, and usually has what we call skip lesions. And I'm going to show you that in a minute. So you have to remember, can occur anywhere in the GIT, from the mouth to the anus with skip lesions. Okay. So we look at that morphology that I'm talking about. Okay. Since we've seen the pathogenesis is in exaggerated inflammation. Okay. So grossly, we will see what we call skip lesions. Okay. What do I mean by that? Patchy involvement. Let me show you what I mean by that. I don't know if I have a better. I thought I'd put yes. Skip lesions. For example, this is Crohn's disease. This is a colon. You see your appendix here. Okay. So when I say skip lesions, is you have normal colon or rectum here, then coming to sigmoid, or normal colon. Then you have ulceration, okay, or inflammation, which is Crohn's disease. Then you have normal, then you have a lesion. Then you come here, you have strictures. You formed ulcerations and they healed by fibrosis, so you have a stricture here. Then normal, then a fissure here or a fistula, then normal, then like that. That's what I mean by skip lesions. Okay, they form skip lesions. Okay, patchy involvement, skip lesions. Remember, it's anywhere in the gut, okay? Then, because of the inflammation, the wall of the bowel is thickened, and I'll show you that. Then you may have a cobblestone mucosa. I'll show you photos. I think that's the best thing. Then you may have strictures because of healing of the ulcers with fibrosis, or healing of inflammation with fibrosis. Then you may have fistulas. And fistulas, as I said, is a connection between two epithelia. So you may have a fistula between the intestine, which is entero, and the skin, which is cutaneous. So enterocutaneous fistula. You may have a fistula between the intestine and another intestine called enteroenteric. You may have a fistula at the perianal region. So from the anus to the outside, around the perineal region, perianal, okay? So you're just seeing fistulas around that region, okay? It could also connect with the urinary bladder, could connect with the vagina for the female. So you can have fistulas like that, okay? So despite me saying that the commonest site, or rather the disease can affect anywhere from the mouth to the anus, the commonest site is usually the terminal ileum, okay? It's like terminal ileum. And then followed by colon, often on the right side, and then the perianal region, okay? Microscopically, we'll see inflammation, okay? Again, which is transmural. When I say transmural, I mean from mucosa, some mucosa, muscular layer, serosa, okay? Then you'll see granulomas, which are non-caseating. Then, of course, lymphoid aggregates from the inflammation, and then we may see the ulcers. I show you that on photos so that you understand. Okay, so this is our intestine. Over here, there's a thing I hadn't mentioned, that you may have sometimes fat. You know, the fat in the mesentery fold around this bowel. Okay, we call that that, as we usually is where this is a very nice normal gut. Then you'll have another inflammatory region, then normal gut. This one has a bit of ulcerations here, you can see, but here is normal. Okay, then ulcerations, edematous wall, but this other part is normal. Not edema. Look here, this one looks very nice. This one is thickened. That's what we mean. Okay, yeah. Okay, I show you another photo. I liked this because it's like fresh, fresh. Not a lot of fixation informally. This has been affixed a little bit, but I want to show you the skip lesions, okay? Here. Then these darkened areas, this ones which you're seeing with holes like this, these are skin, the ulcers, These are ulcerations here. Then normal, here is normal. Then here you have even a deep fissure, okay? Over here like this, you see this furrow? Yeah, this is a fissure like this, okay? Then you end up having, this is normal, this is ulceration, ulceration here, normal, like that. So that's what we're calling multiple salpinginous, like a snake, skips ulcers that spare the intervening mucosa. Okay, you have not been affected, skip lesions. This, I was going to demonstrate the creeping fat, mesenteric fat trying to wrap around the gut here. The one I was showing here, this fat here. You see my arrow here? Here like that. Showing here, fat like that. Then here, this area, they had those skip lesions. They have the ulcers, inflammation, then it has healed by fibrosis. So you have a stricture being formed. This is a stricture. It should have been smooth nicely. You see, like here, normal, very smooth nicely. Here we have now a stricture. Okay, is a constriction. Okay, on the lumen. You may have obstruction and get intestinal obstruction, food not passing properly through that area. So you definitely will have to relieve the obstruction, okay, surgically, okay? That's what I mean. So the strictures I have told about it, so I've described that. I'm just showing you photos. This is a cobblestone that I talked about. You see the way it looks like cabro, like the way nowadays we're doing our pavements with cabro, it almost looks like that. Okay, disorganized cabro, maybe I should say that. Or on your building, like you have to put that thing. It's usually called the fundis call it hardcore, some big, small stones that you call the fundi, then they come, they hit. Yeah, it looks like that, the cobblestone. Yeah, this one, of course, we have, it's in theater. When you're processing it. So this is gross, how they will appear. Microscopically, I said there's chronic inflammation. So look at this. Okay, we may not even be able to see our nice mucosa because there's ulceration, but you can see remnants. So you can see to glance here, the crypts. These ones here. Okay. Then you have marked inflammation. Look at this lymphoid follicles. This is a lymphoid follicle, another lymphoid follicle. All those small dots which are not forming together, they're called, that is inflammation. Then the ones which are coming in together and forming a thing like this is called a lymphoid follicle or lymphoid aggregates. Okay. Then there's an ulcer here, the ones we were seeing. Because you see, you should be seeing this mucosa. As you're seeing this two glands and mucosa, you should be seeing it here also. But it is not present, and therefore we call that an ulcer. Okay. So these are the things I'm talking about here. We'll have transmural chronic inflammation, we'll have lymphoid aggregates, and then you have your ulcer. This is what I'm showing now. Okay, under the microscope. Okay, you see on this other side, you still see the mucosa. But in between here, where we're having even a fissure coming in here and this ulcer, there is no mucosa. That's why we are saying ulceration. And you see a lot of inflammation, okay, with the lymphoid aggregates. I show you another slide of the same. So for the transmural inflammation, that we're seeing the inflammation coming all the way, it is coming all the way. You can see up to the serosa. This is the serosa. And you can see the lymphoid inflammation even in the serosa here. You see it in the muscle here, muscular layer. You have your longitudinal and circular muscle layer. Then you have also here in the submucosa, and then our mucosa here with a lot of ulceration. That's transmural. Then you come here, we are seeing the granuloma, non-cacheating granuloma. This is a granuloma, but there's no necrosis, cacheating necrosis in the middle. It's just a granuloma. Okay. If you had put it at high power view, you'll be able to appreciate epithelioid cells. But now it's not high power. I'll not lie to you. I'll just show you this is granuloma. Okay. So that's morphology. Remember, that's how we are going through it. We have discussed our etiological risk and risk factors, hypothesis in pathogenesis. We looked at morphology, both gross and microscopy. So I was showing you gross here, the gross morphology, then microscopy on this other side, microscopy here. Then now we go to how the patient will present. Okay. Again, remember that it's a long class, so I have done a bit of summaries in what I'm presenting. Okay. So for the clinical features, typical symptoms, we'll have chronic diarrhea. Remember, this is a chronic inflammation. Non-bloody, more common than you'll see in ulcerative colitis, which is giving us a bloody diarrhea. Then they'll have abdominal pain, especially even in the right iliac fossa, because it's happening more in the terminal ileum. Okay, then they may have weight loss, of course, because they get up, sometimes having malabsorption, they're not eating well, etc. They may have a low-grade fever, say a whole year or a month, then you get the symptoms like that. So during the flare, okay, what I'm discussing today is just intestinal, but or GIT, but you can have outside, like in the joints where you'll have arthritis and sacroiliitis. You may have it on the skin, where you'll have erythema nodosum and pyoderma gangrenosum. You may have it in the eyes where you're having uveitis, okay, or sclera being affected. You may have it in the hep and ulcerative colitis, which we'll discuss, where you have primary of oxalates. Remember, when you're having Crohn's disease or this inflammatory bowel disease, you are not absorbing in fat. So with fat malabsorption, when you're being able to, when you can absorb fat, some of that fat joins with different things, even calcium. This fat now will cause high levels of these oxalates, okay? Because it's not being able to bind. You'll go read about it. I think you did in malabsorption in chemistry. We do that in clinical chemistry. You'll read about it. How you'll end up having the stones, and especially the calcium oxalate stones. They're the more common ones. Okay, so that's the clinical manifestations. Other ways is when it's at the perianal region, you may have perianal disease, like you may have skin tags, we have fissures around there, you may have abscesses being formed, okay, and fistulas around that region. And for children, you may have growth delay because of malabsorption as one of the things occurring, okay? Yes, so typically. Complications, strictures, as I showed you earlier, like the stricture I showed here, these strictures, they can cause obstruction. The food coming from this side will not move to this other side because of the stricture here. So one of the commonest complication is an obstruction. Then the fistulas that I talked about and formation of abscesses. Okay, malabsorption, which I've talked about, which may occur. Then the perianal disease that I talked about. And then we may have a risk for the colorectal cancer. Okay, and this is increased especially with long-standing colon involvement. Of course, the risk is higher in ulcerative colitis compared with Crohn's disease, okay? Then, of course, they'll have nutritional deficiencies. And you can add more of these complications. I've just mentioned just a few. Okay? I've just mentioned just a few. You can add more. But of importance is the way I have classified all the things from your etiology, hypothesis, etc., so that you can be able to follow up to complications. I'll discuss diagnosis together after describing ulcerative colitis. Okay. So we move to the next one, which is ulcerative. I'll only discuss the two for inflammatory bowel disease. So ulcerative colitis, again, by defining it, is just from the name, ulcers. So the ulcers which will be formed, okay, in the colon. Now, I need to say something. So for ulcerative colitis, okay, it's more in the mucosa and the submucosa. So it's not transmural like the way we've just seen in Crohn's disease, okay? And mainly affects the colon. This one doesn't come from the anus to the mouth, no. It's mainly in the colon, okay? Usually it starts like in the rectum, then it spreads proximally, okay, to the whole, and then may involve the whole of the large intestine. We call that pancolitis, okay? But mainly it starts at the rectum. I see a lot of proctitis, ulcerative proctitis, yeah, on my desk. Okay. In fact, there's one I was looking at yesterday. They thought it was that. My colleague called me and I'm like, no, 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 no. This one is just an infectious colitis. It is not inflammatory bowel. Okay, it didn't have the characteristics like what we've just mentioned previously. Okay, so again, for its incidence is about 10 to 20 per. I'm seeing it here locally. Unfortunately, there's not much epidemiology on it. Prevalence to 25 years, okay? Affects men and women equally, okay? And there's a familial association, okay? About also affected, okay? Again, non-smokers and ex-smokers have a higher risk. Again, different from Crohn's, where smoking was a risk factor. This one is slightly different. Okay? So let's look at the etiology and risk factors. What do I mean by that? There's genetic, there's immunology, and there's the microbes, environment. Okay, so same story as Crohn's disease with HLA-DRB1 and HLA-B27. You know, like the one for ankylosing spondylitis, which is associated with HLA-B27. It's like that. Yes, it's a strong association. Immune immune response, lifestyle flares, okay, in a genetically predisposed person, stress, infections, use of antibiotics, etc. may contribute. Of note is an inappropriate immune activation. So that's forms the hypothesis is for inflammation. So you end up having the whole mucosa and submucosa having continuous superficial inflammation. Okay. It never goes to the muscle and the serosa. You may have ulcerations. The polyps are, because of inflammation, then you're having regeneration, like healing, like what you'll see when you talk about liver cirrhosis. You'll see nodules. Those are the pseudopolyps that we will see from there. And I show you that just now. Yeah, it will come from the rectum like this, and then move continuously up like that. These are the pseudopolyps using these two heads like this. Remember, it's just affecting the, yeah. Then it can extend upwards to involve the sigmoid, the descending, and the entire colon, which we call pancolitis. Okay, it is continuous, so in Crohn's disease. Okay, then when you look at it microscopically, it's this inflammation. Then the pseudopolyps, which are the healing islands of the mucosa. I repeat again, not inflammation in the mucosa and in the submucosa. We'll see crypt abscesses. This is just neutrophils, the inflammation within the crypts. Okay. Then the goblet cells are reduced. Okay. Then of course the crypts, the architecture. Of note again, there are no granulomas. Okay? None. Okay. So we look at the photos here for proctitis. Okay. Okay. And affect the left side, as you can see here, it's gone all the way. Okay. Not just the sigmoid descending transverse, but also the ascending colon and the scum all the way here. Okay. Yeah. And then when we look at it grossly, this is extensive ulcerative colitis. So like we've taken this, then we've cut, very nice. Then this one, the ulcers. And the ulcers alternate are I'm pointing. Okay. So this person has been done surgery. Okay. They have removed. So these are the small ones. And this is the ulcers in between. Okay. So again, we look at it here. Ulcerative colitis, this is normal colon, but they have the small ulcers, inflammation, okay, with ulceration of them. Okay. And here we have a pseudopolyp. It's just an island of regenerating mucosa, healing. I come here again and show you. Okay, this is a normal ulcerated mucosa, colon mucosa. Then you look here, you're just seeing extensive areas of ulceration, shallow ulcers. They're not perforating, they're not deep. All this, okay, all this that you're seeing here. Okay. then they'll slow off, shed off. Okay, that's what we are seeing. So that's what we see in ulcerative colitis. Okay, so we look at it under the microscope. Sorry, my picture is not very nice, but it will tell you what I want you to see. Like now here, this is a crypt. You know, like a gland like this is a crypt here. This is a crypt here, etc. Yeah? In this one, I want to show you an abscess, crypt abscess. All I mean is neutrophils are inside the crypt. That's called a crypt abscess. Okay. Then around that, you can see a lot of neutrophils. That is the superficial inflammation in the mucosa. In the mucosa. Okay, same here. Any like we see in a normal one. Then we have inflammation here. Okay, and then we'll have crypt abscesses. Okay. So the normal structure is usually disrupted. Okay, so I show you better photos here. Okay, look at our crypt here. Then inside the crypt, we're having neutrophils. So we call that a crypt abscess. Okay, yeah. And then you come here, another small crypt abscess. Okay, they're formed in there. And a lot of inflammation. If you see here, you're just seeing inflammation and you're not seeing the many number of crypts that you should see. So they're decreased in number and then they're distorted. Okay, look at some. Look at the shape of this one, different from this. So they're different. They're disrupted. The architecture is disrupted. Okay, and you have lots of inflammation, as you can see. Lots of inflammation. Here we're having reactive regenerating epithelium, which will form the pseudopolyp. Okay, I said I'm seeing a bit of this. Yeah, like maybe I should look at the data that we've collected this year and see how many. Of course, small, or the Nairobi hospital, that will mean a lot of work and ethical approval. But in small clinics where most of us work, we can easily just look and see. For sure, I know this year I've seen maybe 10. Yeah, of and more of proctitis, the ones in the rectum and etc. Okay, so how will the patients present? Again, the ones with this ulcerative colitis, typical symptoms is the bloody diarrhea, which is like a hallmark of the disease. Then they'll have urgency, always feeling like you want to go to the toilet. Then they'll have tenesmus. You're feeling like there's something pulling your anus. You feel like something is pulling it. Then they have mucus in the stool. Then they may have low abdominal pain. And they're like that in the Crohn's disease though. Then disease extent patterns. You'll have if it's affecting the whole of it, pancolitis. You'll have even systemic symptoms of fever, anemia, etc. Okay. Again, as I said, it's a systemic disease, so there's extra-intestinal manifestation, similar to Crohn's disease, okay? Just as we had seen earlier. Okay? So complications, one of the complications is a toxic megacolon, meaning mega is becoming big. So because of the ulceration, inflammation, so you'll end up having exaggerated, endotoxins and all that being produced, and then they will lead to weakening of the wall of the gut. Then you have it dilated. That's a megacolon. It becomes big. This can be life-threatening. You have to take them to theater, etc. Then they may have severe bleeding. They may have perforation, but it's very rare because we saw the ulcers are superficial. Okay. The thing that is more important is the risk for colorectal cancer. Okay. So duration, they have a higher increased risk compared to Crohn's disease, and the duration is 8 to 10 years. Like from the time you get the ulcerative colitis, that's when you can develop malignancy. It's more in pancolitis than in just one area, and is also associated with primary sclerosing cholangitis. Actually, they say the etiology for PSC is because of ulcerative colitis and the microbes that are there. Then they cause an exaggerated response now in the biliary system. Okay. We may have strictures, but not as common as Crohn's disease, because remember, ulcerative colitis is mucosa and submucosa. It's superficial. Okay. Nutritional deficiencies, again, because of diarrhea and not absorbing malabsorption, which may come up. Okay. Yes. So blood test, which is now for both diagnosis for both Crohn's and ulcerative. So of course, you'll start simple and do your CBC, where you'll find they have anemia, like an iron deficiency anemia, because it's a chronic disease. Then they'll have, when it's active inflammation or during the flares, they'll have elevated markers of inflammation, your CRP and ESR. Then chronic disease may lead to abnormal proteins. You'll see that in your liver function test, and they may have electrolyte imbalance, especially when they have a lot of diarrhea and severe disease. You'll see that in your kidney function, in your UACs. Okay. Then other tests to look for malabsorption, like ferritin, iron, B12, folate, vitamin D, nutrition deficiencies. You just have to do the tests for that. Then of importance is that we can do a stool test where we look for, which is very highly useful or sensitive, what we call fecal calprotectin. So this fecal calprotectin is very sensitive. It's an elevated marker in inflammation, and it points to us a lot that you have inflammatory bowel disease. It's a test that we are doing a lot now. I think it's a bit expensive, but I know it. Like in Gertrude's, I think they charge, was it 20K or it was how much? And Nairobi Hospital is, around that. Of course, some of it is sent outside the country. Okay, but yes, it's there. We are able to do it. Then you can also do stool for culture and look for even infections, just to exclude that it's inflammation is because of IBD and not infectious colitis. Okay. Yeah, I know in some books you'll read about the P anchor. Go read about it. It's a better marker for PSC, the primary sclerosing cholangitis. It may be elevated, but it's not so specific when you do it for IBD. Older books will say that. But now we are moving from P anchor. P anchor is pan-neutrophilic, anti-neutrophilic, cytoplasmic antigen, something like that. I've forgotten it in full. Yes, but we're moving. We are now using more of the calprotectin than the P anchor, okay, for the diagnosis. Yeah, highly sensitive. Okay. Special diagnostic workup. Now, this was the original one. I was just doing blood tests, doing stool, but no, special and the gold standard, to make a diagnosis is colonoscopy. Okay, so you put your scope inside, then you look for those skip lesions, you look for the pseudopolyps, you look for the ulcers. Okay, that confirms for you the diagnosis. Okay. Then you're able even to take biopsies, and in the biopsies now you look for the morphology we've discussed. If it's ulcerative colitis, you'll see continuous inflammation of the submucosa and the mucosa. If it's Crohn's disease, you'll see the skip lesions, a normal part, then abnormal, normal, then abnormal, like that. Okay, and even with strictures. We may also do an upper GI endoscopy. Colonoscopy is from the anus upwards. Endoscopy is from the mouth esophagus downwards. Because we said in Crohn's disease, it can affect the mouth all the way to the anus. So you can do an endoscopy just to rule out if there's upper GIT involvement in Crohn's disease. Okay. Then imaging is also done, like a magnetic resonance enterography, especially when you think there's Crohn's disease in the small bowel, in the small intestine. Okay. Then you can do CT abdomen to look for complications. Okay. So today I mentioned one or two things. This is just the assignment that I'm giving you. I know you'll ask me about treatment. There are different methods of treating. I will not go into the details. You will check that out. Yes. There are different groups of drugs that people are given, diet modification. Let's not go into treatment for now. Okay. But I give you an assignment. I want you to go and look at the differences between Crohn's disease and ulcerative colitis. This picture is one of the things to help you. The way ulcerative is and the way Crohn's disease is. And that is what I want you to read as you read about treatment. And I'm done with the first part of our lecture. Today we are not active, but we are good. We have many students today. At least we are very many. I'm happy. Breathe in and out and ask questions.
Could you confirm whether IBD is synonymous with IBS?
No. IBS is irritable bowel syndrome. It's not inflammatory. It's slightly different from IBD, but we are not going to discuss IBS today. That is irritable bowel syndrome. Characteristics, some of them are different.
Okay.
Yeah. So for IBD, and that's why I talked about the more common ones that we would be discussing and what you see. If you now go to IBS, there are a million other things that we would need to discuss. So we just stick to IBD. I'm waiting for questions as we breathe in and out. Give me 2 minutes as I give you for breathing in and out.
Okay, I'm back. I just take 5 minutes. Hope everyone else is also back. No. Somebody else was stepped out. We were 35 or 36. There's a question. Marion is asking, are there any similarities of IBD to celiac disease? Okay, now celiac disease is these people who react to gluten. Now, because of that problem of gluten, now when they eat something which has gluten, now they activate the inflammatory system, which is different. You know, in IBD, we've said there are those genetically predisposed who will then now form an exaggerated immune response. So for celiac is gluten related. These are the ones, as you've seen, the hypothesis is different things. So yes, I know I didn't discuss gluten because it wasn't part of that, but the GIT has a lot of things. But yes, for celiac is gluten. Yeah. I've seen a bit of people also locally saying they eat gluten-free things. I mean, when you go to restaurants, if in other countries, of course, they even write for you that this is gluten-free, this is whatever. So yes, because of celiac disease. Yeah. In fact, I'll give homework now that Marion has mentioned people to go and read about celiac disease. I know I think it's for another group where we had to discuss plus all those. So read about it. Read about celiac. It's related to gluten. Okay, so now we can continue. So the next and final part is GIT tumors. So before I start, for the next 2 minutes, people to mention any risk factors or anything that you've heard about in the GIT tumors. Mark you, we're only going to discuss esophageal, and I think esophageal must have been done, but I doubt. Esophageal, stomach, and colon cancers. Anything that you've heard about GIT tumors, those ones, esophagus, stomach, or colon, whether it's risk factors, whether it's the types, whether it's, a patient you've had, the presentation, how they presented, just anything, so that it brings out, so that we have psych for the class. You're a bit dull. Timothy, okay, Timothy is already typing. I don't know if it's Timothy A who is typing or Timothy B. Yeah. So that we have some psych for the class. Problem is that I'll only remember a few people. Joy, say something. I see people are typing, yeah? I think it's both Timothy's. Risk factors, alcohol, correct. You can even unmute and just say something. So alcohol is a risk factor, correct? Family history, okay, correct, especially for, you'll see even gastric and colorectal. Very true. A, that's it. Jaconia, I see. Jaconia Onyango is saying something. Unmute and say something, my dear people. Thank you, H. Pylori. Yes, stomach. Think H. Pylori. H. pylori. We just learned about it the other day. Keep saying something. No one else is typing. No one is unmuting. How sad. Okay, fine. Even Julius, you have not said something. At least both Timothy have said something.
Yes, I think for me, just have a weird experience that maybe I also want to understand in this class. One of my friends' dad had colon cancer.
Oh, sorry.
And they did radiotherapy, and he seems to just be okay. But after a short while, he just developed the liver got swollen, and we lost it. And the explanation from the oncologist was that when they did, they thought they had managed the tumor, because even they had done the resection of the place where the tumor was. And it was that it had metastasis to the liver. And just to understand how comes colonic tumors, they metastasize very fast to the liver than any other part or to other organ in the system.
Okay, so we will discuss that for you. When we do the
Yes.
class, we'll see whether we can answer some of your questions.
Thank
Great,
you.
thank you. That's what I'm asking, whether people have an experience. But I see my two Timothys are also telling, yeah, they're both Timothys telling us things. Thanks, Julius. Timothy, also we have Tundo talking about radiation. Timothy's, both, they've talked about also the one I've just talked about. We have just finished inflammatory bowel disease. And I said in ulcerative, risk factor for colon cancer. And then you prefer not even saying it. Yeah. Anyway, okay. Let's first finish. So GIT tumors. And I agree. Of course, maybe people even have had patients or relatives with one of the disorders. So today we're going to discuss them. Yeah. For me, I usually have, because I see these patients quite a couple of times, I see a lot of GITs. So I have many points to say. Okay. So let's do an intro. I'll start with an intro. So etiology and risk factor, just general. This is an introduction for all GIT tumors. Then we'll go to each. Okay. I just decided to put this instead of just going directly, just a general overview. And I think they're just 5 slides. So we look at the etiology and risk factors, general, as I say. So lifestyle, which we've mentioned, smoking and alcohol, and you'll see this, they're major contributors, especially to esophageal carcinoma. The high fat and processed meat diet, we will see, and low fiber, very common in colorectal carcinoma. They also mention about physical inactivity because of obesity and all that. Then chronic inflammation, very well mentioned, H. pylori in the group is associated with that. Okay. And then we'll also see Barrett's esophagus because of inflammation, the reflux associated again with adenocarcinoma. Okay. We've already seen about inflammation in Crohn's disease and ulcerative colitis. So that's another risk factor. Genetic syndromes, okay, we'll see a lot of those. Familial adenomatous polyposis, adenomatous, which is the Lynch symptoms, all those which are genetic syndromes that lead to colorectal cancer. Then environmental, especially when you have high nitrites. The nitrosamines pumps those nitrates, and the nitrates damage the DNA. Okay. Aflatoxins, like we see in hepatocellular, but then the one I didn't mention, that was chronic inflammation, but infections as it is. We have for H. pylori, we have HPV for the anal ones. You can have squamous cell carcinoma. And even sometimes they say HPV for esophageal. Okay. Then hepatitis B and C, those ones also for your for hepatocellular. Okay. Others say those things of immunotherapy, radiotherapy, abdominal radiotherapy, immunosuppression, all those things. Of course, these are just some things that they say can predispose. Okay. So classification, how we are going to run it in this class, how we are going to classify, we'll classify according to behavior. Just the same way we did by behavior. That's how we are classifying. So benign, we look at polyps, adenomas, etc. Then malignant, we look at the different histological classes of malignant. Mainly, it's usually squamous cell, the epithelial ones, which is adenocarcinoma and squamous cell. Okay, so adenocarcinoma is almost everywhere. Then squamous cell is esophagus. Then we'll see the other types of tumors we may see there. Okay, like your neuroendocrine tumors, like they always said carcinoid in the appendix. So you can have it in other places. Then by side. So that's when we'll go to details. So we'll talk about the tumors in the esophagus, in the stomach, and then colon. I'll put colon all of it together. I'll not divide it as small
large, and anorectal. All those will be 1. Okay, so the 3. Then for pathogenesis, very important, general principles is that you'll have chronic system that we're talking about. For example, which is dysplasia and then the carcinoma. Okay. Then we look at for colon cancers, the relationship of the mutations that move from an adenomatous polyp, then it becomes a carcinoma of the colon. Then other environmental carcinogens that we discussed in neoplasia in term 1, okay, like cause DNA damage like alcohol, smoking. Okay. Then microbial effects like your H. pylori, which by itself can cause instability, genetic instability, okay, especially when the virulence factors that come with it, and cause T cells also to be exaggerated, and the inflammation from it. Then there are those for the neuroendocrine tumors or the carcinoids. We have those that are related to hormonal and neuroendocrine pathways. Again, we'll not discuss all this in details. This was just a general, as I'm saying, these are things related to the pathogenesis. There are some that I'll explain further when we look at each. Others that, like neuroendocrine, I'll just leave it. Okay, a brief molecular basis. Some of the mutations we see, I mention them because, as I said on Monday, we are moving to precision medicine, where we want to target where the mutation is and give treatment according to that mutation path as an individual, not lumping everybody together. So we have the APC mutation, which we are going to see in the colorectal cancer. Then we have the KRAS mutation again. Then we have the tumor suppressor gene transforming malignancy, which is the P53. Then you have together, now you have those ones being added the wrong way. Okay, I think we did that in biochemistry. So we'll see that, which is common with the Lynch syndrome, okay, or tumors on the right side for the colon. Then HER2 amplification, which you've seen in gastric tumors. In fact, nowadays, every time I make a diagnosis of a gastric carcinoma, I have to add my HER2. Okay. Then SIKIT mutations, which we find in gastrointestinal stromal tumors. It's CD117, is it? SIKIT, yes. Again, very important when we pick the SIKIT mutation, because you can give targeted treatment like the imatinib. Okay. Histological types I had already mentioned, so I think I'll skip this slide, because we said, of course, they're either epithelial, which is adenoma, adenocarcinoma, or squamous cell carcinoma. Then you have neuroendocrine, you have the mesenchymal, which is GIST, and then you have the lymphomas. Okay. So morphology, how they will appear, okay. They may have polyps, or they be exophatic. I'll show you photos of that. They could be ulcerated fungating lesions. I'll show you photos of that also. Or they could just infiltrate, moving across nicely, not protruding, but just moving across. That's infiltration, like what we see in Linitis plastica in the diffuse cancer, gastric cancer. Or could be just below the mucosa, like what we see in a GIST. Okay. Microscopically, we will look at all these under each type. So we skip this as an intro. Okay. Diagnosis, general approach, very general. But what you need to know, the red flags. If a patient presents with dysphagia, and what is dysphagia? Difficulty in swallowing. Okay. Patient presents with unexplained weight loss. Patient presents, you do a CBC, you're seeing iron deficiency anemia. Patient tells you, I have bleeding. When I look at my stool, I see blood. Patient tells you, my bowel habit is changing. Siku hizi ninaharisha, mara mwingine ni ngumu, mara mwingine I'm just constipated. All those. Okay? Persistent vomiting, especially when they have dysphagia and there's blockage. They'll just vomit. Sometimes they may feel an abdominal mass. Of course, by the time they're feeling an abdominal mass, things are thick. Okay? So those are red flags that you pick. Then investigations. The gold standard is, if it's in the upper GIT, is endoscopy. If it's in the lower GIT, it's colonoscopy. And then when you do the colonoscopy or endoscopy, you take your biopsy. That's the gold standard. Okay. Then the other things is imaging, where you'll do for staging, you check, because you've seen now there's stomach cancer, you want to see whether it is gone to the lungs, etc. So you do CT scan, MRI, all those. You do a PET scan. Now we're able to do PET scans in our country. We're having a PET in KUTRH, and we have a PET in Nairobi West, and they're able to help us see whether there are any cases that have gone. I have seen part of my patients, I think 2 of my patients have had a PET. They had made a diagnosis of esophageal carcinoma. Then tumor markers, and here is for your colorectal cancer because of the CEA, which helps with monitoring and management. Okay, it's not useful for diagnosis, it's just useful for monitoring as a workup. Okay, so at diagnosis, before you do anything, we check the level of CEA. Then from there, we'll be seeing whatever treatment we are giving, is it becoming lower? Okay. Then again, for colorectal, we usually do a FIT. FIT is fecal immunochemical tests for blood in stool. Okay. Yeah. So that one we can use it for screening. Okay. And triage. Okay. So principles, again, general for treatment, you can do surgery. Mainstay for tumors which are localized at an area, you see this is it, so we can remove. Okay. Endoscopic therapy, where you want to remove the polyps, etc., which you can be able to remove. Then you have chemotherapy and radio. Okay. Sometimes you do neoadjuvant. Before you do any surgery, you first give some chemo or radio, and then you remove the tumor or the organ. Then targeted therapy, like for gastric tumors, if they're HER2 positive, you give an anti-HER2. Then for GIST, you are giving imatinib. Then for the ones which you can do immunotherapy, especially for, I'll teach you those ones in a bit. Then palliative, very important. For their symptoms, give medication, relieve their symptoms. If they're having a stricture which has obstructed your mother, stent is like a tube, and I'll explain in a bit. Then do pain management. Now, that which I've explained is general. So now we will go to each. So the way I've broken it down is the same way we'll look at in each. I did general so that if you sleep before I finish my class, you'll have gotten the general main part that I wanted you to get. Okay? Then now you'll be able to, when you're doing your revision, to read each slowly. Okay? Yes. Now, I think I'll start by telling you, I'm seeing a lot of esophageal tumors, esophageal carcinoma. Okay? Before, we thought it was more, because there's a study we were doing. People in Tenwek, you know that area, Tenwek? Okay, now I'm saying Tenwek. Kericho, because Tenwek is Bomet there. Eh? So they were doing, there's that hospital, Tenwek Hospital. They do a lot of work. Eh? The hospital with a lot of Wazungus who donate many things. So they were looking at esophageal cancer and linking it to the chronic irritation because of the tea, hot tea. Eh? But now we say that is not the only thing causing it, because we were trying to also compare with what we see on our side. So we had patients from Muranga, Kitui, Garissa, who are also presenting a lot with esophageal cancer. So we're trying to compare what else is there, because Kitui people don't drink tea. Okay, Muranga they may try, but not much. Muranga is more of coffee and different. Garissa, So we were trying to compare. Of course, that study, I need to find out what they found in the finishing, but they saw the other genetic predispositions. Okay, but hot tea on that side is one of the other things that is associated with it. Okay, so let's start esophageal. I was just saying what is going on, what we see, but I see a lot of esophageal, even in young people. I think the youngest when I was in school was a 20-year-old. I was doing my MED, and I remember the surgeon came, the registrar surgeon. Now you speak residents first before you go to the main guy. He actually came to the lab to see for himself. Like, hey, how can you call this cancer? And it's due this, I think he was 17 or 20. So he came, we looked together. Then I told him, I have looked with the professor. It is correct. The diagnosis is correct. But now from my practice, I am seeing I think my youngest one on my desk right now is 42, esophageal cancer. What is it younger? Am I confusing it with the laryngeal? Laryngeal I have seen even at 30-year-old. No, esophageal, my youngest is, I think right now is 40, if I'm not wrong. Anyway, etiology, esophageal cancer. So we'll only discuss two types, the way I said there. The squamous cell carcinoma and the adenocarcinoma. Benign of esophageal is more of a papilloma and is not as common. So we leave it out. Okay, so let's talk about malignant. Squamous cell carcinoma risk factors. Major risk factor is smoking and heavy alcohol use. Okay. Others are nutritional deficiencies, the ones I talked about. Then chronic irritation. It could be because you have an achalasia or you have caustic strictures or thermal injury, like the very hot drinks, okay, that we mentioned. Then HPV has also been associated in certain regions, okay? Then sometimes we think of socioeconomic factors, I'm putting it as a query, you'll go check. They say low socioeconomic sometimes or high, associated, again, because of low fiber, diet, whatever people are eating, or fruits, okay? Now, for the squamous cell carcinoma, it's more in the upper third and the mid third of the esophagus, okay? Which is very different from the adenocarcinoma. So the risk factors for adenocarcinoma, major is Barrett's esophagus. And we've already done Barrett's esophagus, so remember what it is, okay? Then you have chronic gastroesophageal reflux disease. And the other one is smoking. It forms a moderate risk. And then, of course, the high fat processed foods. Site for adenocarcinoma is lower third or at the gastroesophageal junction, okay? I need to say, just to make us remember, when you have the esophagus, the wall of the esophagus is made of squamous epithelium, okay? Now, at the distal end, when you have reflux disease, where you're having acid from the stomach regurgitating backwards or refluxing backwards into the esophagus, there are cellular adaptations to that irritation of the acid. So what the esophagus does, it changes its epithelium from squamous and it becomes like the one in the GIT, the other lower GIT, the gastric and in the intestine. So you have an intestinal type or gastric type of mucosa, which is able to withstand the acid irritation. And that is now the Barrett's esophagus, okay? Now, that Barrett's esophagus can undergo dysplasia, okay? Changes. And that dysplasia, depending on how it's developing, it can go to high grade and then become a carcinoma. So the metaplasia will form an adenocarcinoma, which is what I have just explained right now or displayed in this slide. Adenocarcinoma, the risk factor being Barrett's esophagus or chronic gastroesophageal reflux disease. Okay, and the reason why it's being located at the gastroesophageal junction or the lower third of the esophagus is because that is where the changes are occurring. That's where the reflux is. Okay, yes. So we move. Okay, I needed to explain this part about the sites. Okay, so pathogenesis. For the squamous cell carcinoma, it's more of the chronic mucosal injury, which leads to esophagitis, inflammation. So esophagitis is a major thing. Inflammation of the esophagus in causing squamous cell carcinoma, okay, which leads to dysplasia and then carcinoma, okay. Major things like when you look at your tobacco and alcohol, which I said are major, they cause DNA damage and impair the repair processes of the DNA, of the mutated cells, okay. Other things like the nutrition deficiencies promote the dysplasia, okay. So squamous cell carcinoma, again, as I said, it's coming from the squamous epithelium, and therefore it is going to cause keratinizing or non-keratinizing carcinoma, okay. Now we move to adenocarcinoma. I explained about adenocarcinoma. That's because of carcinoma. Okay. What is a reflux, it's from acid and bile reflux, which cause oxidative stress. And then that causes the genetic instability, okay, of the cells around there, leading to the dysplasia and carcinoma. Okay. Again, for the adenocarcinoma, they are gland forming. So the malignant cells form glands. And when you look keenly, you will see a background of the metaplasia, the intestinal metaplasia. Okay. When I'm looking at them under my microscope. Okay. So that's brief on pathogenesis. I have not mentioned those molecular things. For now, this is what you need. Okay. So we move to morphology. Remember, I said morphology is what you see grossly with the open eye and microscopically under the microscope. So for the squamous cell carcinoma, SCC, many times they're polypoid or exophatic. I'll show you photos of that. They may ulcerate. I see my people presenting like that many times, or infiltrating mainly as a mid-esophagus, okay? So what usually happens, the endoscopist usually tells you, the scope which they put inside there, like the scope I was showing you for bronchoscopy, but now it's not going to the trachea, it's going to the esophagus. It has measurements. So it will tell you from the incisors up to where they find the lesion. Then it tells you how many centimeters. So they write for us and tell us it's like 25 centimeters to the upper incisors, something like that. So they're able to tell where it is. Then they look at it and tell us whether it's polypoid or it's exophatic or if it's ulcerating. They're able to tell, okay? Yeah. And then sometimes it could be on the wall and cause thickening of the wall of the esophagus, which will cause a stricture and therefore obstruction. Okay. That's for the squamous cell carcinoma. For the adenocarcinoma, it's at the gastroesophageal junction, distal esophagus. Again, that one may be nodular masses, masses around there. And often it's adjacent to a Barrett's mucosa. Okay. Microscopically, squamous cell is like anywhere else, like in the skin, in the vulva, in, ectocervix, wherever. It will show abnormal squamous cells, atypical squamous cells in the mucosa, and they sometimes can invade all the way to the muscularis propria. Okay, if it's a well differentiated, it shows a lot of keratin, forming keratin pulse. Okay, I think we saw that in neoplasia. Okay, then for the adenocarcinoma, they'll form glands, so the appendixes, something like that. Okay, then adenocarcinoma, sometimes they may have signet rings. I'll talk about that when we talk about the stomach. Okay. Sorry. And I show you that. So this is what I'm saying. So when the endoscopist, the gastroendoscopist or the surgeon does endoscopy, so they've put the tube. I hope you can see my cursor. They've put the tube. So the tube is showing us now this area. So this is the mass. This is when you go here is the stomach. So this is a distal part of gastroesophageal junction, distal part of the esophagus. This is the mass. This is how they see it. You can see this is protruding, Yeah, it's protruding. It's a big mass protruding and you see, so this is the only hole that is showing us that we're headed to the stomach here. But this, and so that's why this patient may vomit. Will tell you they feel chakula inakwama, haiendi. That's dysphagia. They'll present like that. Because of this blockage. Okay, this is protruding outwards like this. Here it is, and you have also other lesions, multiple lesions. You can see even this one here. Okay, in that patient. So this one is on this side and on this other side. Because I said sometimes could be infiltrating and for the other side they see. So you see the lumen. The lumen has been decreased. You see here, they're trying to swallow. You're trying to push food in this constricted area. So of course you'll struggle. So I have dysphagia. And sometimes this might go until ifunge kabisa. So there are different stages of dysphagia. So they will tell you, when I eat, ugali siku hizi inakwama. So I have to drink a lot of water to push it. Then they come and say, no, even that ugali doesn't go. So I'm now doing fluids, not working. So they have now stage 4 dysphagia, swallowing. So that's why I said red flags, dysphagia. Here is the reason why. Okay, so we've seen grossly here, I've said in adenocarcinoma, which you're seeing the masses here. We can see these ones which are exophytic, this, and also stretching on the wall. Okay, that's how we see them. Then now when we come in, like here and cut, see this one, we resect. Let me use the correct terms. If you came here and resected, they and maybe another part proximal here. Then bring on my desk, this is how it will look. Okay, for example, this one is distal. Okay, so this is your esophagus here. You can see here, this is esophagus, and then this is stomach. So you can see the rugae, okay, in the stomach. It here, all this is tumor. This is a cancer at the distal end of the esophagus. Okay, yes. So this is more of an adenocarcinoma. Okay, yeah. We look here again. Now here, we look at it under the microscope. You can see how ugly. So when you take this and do them under the microscope, these are the ugly cells, which is cancer. That's how it looks. I show you more. Now here, I'm just showing you this when we cut. So this one is in mid-esophagus. This is your stomach down here. So this is where the tumor is. We're calling it T. And this is normal squamous epithelium of the esophagus. We call it put on the slide. You see how nice normal squamous epithelium looks, okay? Like a picket fence. Very beautiful. This is the mucosa, submucosa, etc. Very beautiful. Now we come to the one called T. We put in our cassette. We've processed. Here it is. You can see the nests of tumor cells. Look at this. These are nests of malignant cells with a desmoplastic reaction in between, an inflammation in between. These are nests. They're not a nice picket fence like this. Okay, you can see this is one nest. This is another nest. This is another nest. This is visual. Again, another squamous cell here. This is the stomach. This is the mid-esophagus. And this is where the ulceration and the tumor is. For here. Okay. Yes. So diagnosis. First of all, the red flags that I'm talking about. Progressive dysphagia. From your ugali to your liquids. Telltale sign. And you have seen, I have told you reason like this. Okay? Dysphagia. Okay? From solids to liquids. Then unintentional weight loss. Every time someone is asking you, are you losing weight? Is it intentional or there's something? It's unintentional. You're just losing it. You're not exercising. You're not watching your diet. You're just losing. Then persistent vomiting. We have seen the reason why you'll vomit because it's blockage. Okay. Then they have iron deficiency anemia because now you're not even absorbing. Okay. Then long-standing a history of alarm. But now, because that's how they'll present. What about the investigations? Gold standard, number 1, endoscopy and biopsy. And we have seen. And look at it under the microscope, which shows you these tumors. Shows you these tumors. That time you just pinch a small endoscopic. So gold standard, endoscopy and biopsy. Then other things for staging, you can do a CT scan of the thorax, abdomen, etc. You may do endoscopic ultrasound staging, okay, to see the depth. They do a bit of this at MTR. Sorry, maybe they do in MTRH, but I know KUTRH because I send patients there. And sometimes I follow up with my patients or with my oncologist quite a bit. We are always talking. So I do a lot with those guys of KUTRH. I don't sit in a KUTRH at all. Don't speak. Okay. A PET scan again to look for metastasis. And then sometimes we have been seeing that for the esophagus, they can be HER2 positive. So you can give drugs against the HER2. So general management with early stage disease or surgery, and you've cut, you've resected here and here, like this. So the part you've left here, you connect it to the stomach, to the part here. So that's an anastomosis. So you do resection and anastomosis. Okay. Then locally advanced tumors, you first do neochemotherapy, chemoradiotherapy, yeah? Especially for like squamous cell carcinomas, and some places they do even for adenos. Okay. Then surgery to follow. Okay. Metastatic tumors, again, those ones now you will not operate, because they've already spread. So they are therapy regimens are these. You guys are better placed than I am. But HER2 I can mention. You can do targeted therapy for HER2. Okay. Then action, put a stent. You see, if these ones have come, this one has joined, and this one has joined, you put a tube here in between. That's called a stent. So at least to help with this obstruction. So you'll have been putting a tube in between here. That's what we mean a stent. Okay. Then radiotherapy for pain and dysphagia, and then nutritional support. These are the different things that you can do. Okay. Questions? Or do you want to ask questions at the end? That's for esophageal. Do we see esophageal a lot? Yes, I do. I see a lot of esophageal. In fact, yesterday one that I was looking at, they can say they saw a mass, but what they gave us was a very small part of normal and very small abnormal. So we just called it full thickness dysplasia. They go in and cut again and send us. Yeah. Okay. So we go to the next. Gastric tumors. Are you there?
Yes.
Hello?
Yes, we are there. We are there.
Okay. Mmenyamaza. So now it gets to a point I am just wondering.
I wanted to on hot drinks.
Go ahead,
It
Juliet.
should not be, or it should be.
Sorry?
I'm saying
Mm-hmm.
for the hot drinks. Yes, this has been in the Vine media, where they talk about taking hot drinks can actually is contributing to esophageal cancers. My concern is how hot is this? Are we able to differentiate the hotness that is really dangerous to the esophageal lining?
Julius, let me just be honest. I've just put up the slide that I showed of the thermal injury, which is correct.
Yes.
For all the things that you hear, it's the same thing that I said. You remember when we were talking about lung cancers? And I said I have an uncle who was smoked. He didn't die of lung cancer. He died of other things. But he had smoked for more than 40 years. But him cancer. So it means there's another genetic. There's another genetic susceptibility in a person. So you may be taking lukewarm, like your heart is not very hot, comparing to another person, but because they're genetically predisposed, them they get the disease, you don't get it. So it's a thin line. There's always another thing. It's not just that alone. That's what I want to say.
Okay.
So you can't evaluate and say very hot is temperature of 30 and the other one is 10. There's something there because very many people in the villages, you see like now Abadeas, it's very cold. And so people in Abadeas are always taking hot drinks, but we don't see much of esophageal there. So there must be another genetic predisposition on this other person. You follow?
Okay. Yes. That's okay. Thank you.
Yes, that's the reason. I didn't go to molecular today, And of course, as I said earlier, the study's been done. And the hot tea, the one for Kericho, I don't have the data. I lost contact with the guy who was working there, who used to do a lot of this, and he left. So until we meet in conferences, that's when I'll be able to ask him. He's always traveling up and down the Africa, the world. It's a hard person to pick, but I'll look for him. I see what the many studies he's done and what he's found. Okay, so let's go to gastric. We'll do gastric, then colon, then we finish. So gastric tumors, colon, I'm putting all of them together, so don't worry, we're almost done. And most of my things are photos. So gastric tumors, etiology and risk factors, again, environmental and lifestyle. Environmental, H. pylori, which was already mentioned, strongest risk factor for non-cardia gastric adenocarcinoma, the ones which are not the cardia. You remember the stomach is divided into different parts. Cardia many times will be because of reflux. Then like, connected with like the Barrett's esophagus, have you just seen? It's the upper part. Then diet, nitrates. Nitrates, very common. Now, this as a cause is reducing because we now don't preserve our foods by smoking, the way we used to do, because now we are using the refrigeration. So it's a bit different for these nitrates. Then we have smoking, again, a very high risk factor, and alcohol, okay? Then medical conditions, like when you have chronic atrophic gastritis that you've already covered, that's a risk factor. Pernicious anemia, again, related to atrophic gastritis, okay, with low, the alcohol, whatever, all those things, autoimmune, very much there as a risk factor. And I know when we discussed gastritis, we mentioned. Then genetics, hereditary, as was mentioned, is there, okay? In fact, they say people who have inherited, there's a mutation also, the E. Catherine's mutation, which is associated a lot with the hereditary type of diffuse gastric cancer. The Lynch syndrome, which we will mention in colorectal, you will see a bit of risk higher than female. I don't know, because I see both of them the same nowadays in practice. Increasing age, I'm trying to remember the youngest I have had for stomach. I see a lot of those. I think they're already past 40s. Okay. Low socioeconomic status again, because I think food related. Then for the intestinal type carcinoma, I'll explain about this Lorraine classification. Mainly we see people getting it after the age of 50 and males. Then for the diffuse type, I'll explain about that, occurs at an earlier age with more of the females having it than the males. And I'll explain that in a bit, the classification. Okay, so classification, as I said, benign and malignant. Okay, so for benign, we see adenomas, which may be pre-malignant. We have hyperplastic polyps, they are hardly malignant. Fundic in the fundus, gland polyps, those ones are related to people taking PPIs a lot, the proton pump inhibitors a lot. I see a bit of this, like this, I think I've seen 2. Okay? Hyperplastic polyps, I have seen quite a number. Then you can have benign tumors of the mesenchymal, the muscle, the leiomyomas of lipomas. I haven't seen that. Okay? For malignant in the stomach, the commonest, 90 to 95%, is adenocarcinoma. Okay? Others is the GIST, the gastrointestinal stromal tumor, which is in the mesenchymal type. Have I seen this? This year I have seen two of GISTs. Are they 2 or 3? 2. One was so big, humongous. And we even did the CKIT builders etc. Lymphoma, I just saw one yesterday, which is still disturbing my head as we speak right now. I saw a mild lymphoma. I'm very stressed about this patient. Actually, because I have not believed it, I have sent it to my colleagues to see it. Okay, I saw it. I showed my colleague, they're like, yeah, why are you? I'm like, it's a lymphoma. But then it's like, what is wrong? And I'm like, I haven't shown you the other history of the patient and the age of the patient. Do you know, until even 10 p.m., we were still discussing that patient. It can be that worrying. At 10 p.m., I'm telling him, I don't know that I'll have time to go to Nairobi Hospital in the morning to discuss with my colleagues there. If possible, maybe in the afternoon. Like I know I have classes and I have meetings in the morning. yeah, we were discussing up to, because it's a 20-year-old. And I'm like, oh my goodness. And there are many other things, it's very disturbing. Anyway, another one for the stomach is a neuroendocrine tumor. Yesterday I reported one again of the stomach. Yeah, they're not common, but I saw. Adeno, I see very many times, adenocarcinoma. So for this adenocarcinoma, which you said forms 90 to 95%, we usually have the Lorraine classification, okay? So Lorraine classification divides it into two, intestinal type and diffuse type. So intestinal type is the ones that are forming glands, okay? And it has a strong association with H. pylori infection and other environmental factors that we saw previously. Then the diffuse type is poorly cohesive. It's infiltrating. It's the one that forms on the wall, okay? And it has those signet ring cells or mucin, okay? That's the type. I see both of them, I think, equal rate on my desk. Unfortunately, I think that's what I can say. I see them equal on the desk, okay? So what's the pathogenesis for this? So for the ones which are H. pylori associated, you'll have H. pylori causing chronic active gastritis, which undergoes metaplasia, then goes to dysplasia, and then forms the cancer. And this one we get now the intestinal type of adenocarcinoma. Then there are those that are autoimmune gastritis related, okay? So there's loss of the parietal cell. Then we have the aclohydria. Then we have high levels of gastrin, hypergastrinemia. Then these ones lead more to neuroendocrine tumors or the adenocarcinomas too, okay? Then the diffuse type is more related to a mutation in the E-catherines, okay? The ones for adhesion, cell-to-cell adhesion. I think you remember that from your inflammation. I think it's usually the second topic we discuss in pathology. So the cell-to-cell adhesion. So you have the E-catherines. So there's a mutation in that one, and that leads to our diffuse type gastric adenocarcinoma. Okay, so the cells are scattered, they're one, they're diffuse, they're not joining like forming glands. No, they're scattered and infiltrating. Then other environmental factors, your nitrates, okay, which cause damage to the DNA. Okay, so that's brief pathogenesis. Okay, so the molecular basis, I've already mentioned your E-catherine mutations for the diffuse type. Okay, then tumor suppressor gene P53 mutations can also be picked in advanced disease. HER2, as I said earlier, amplification, we have seen it, okay, in the intestinal type, not for the diffuse type, for the intestinal type. And so nowadays, when I see an intestinal type gastric carcinoma, I do a HER2 so that they can do a targeted therapy, chemotherapy. A bit of microsatellite instability has also been seen, enlightened, because I remember that day my oncologist telling me, Doc, I need for us to do MSI in the gastric. And I'm like, hey, gastric, Doc, it's not a colon, it's gastric. They're like, no. Now, nowadays we are trying that also, because sometimes if we get that microsatellite instability, we call it MSI, it may respond to immunotherapy. Okay, so we are also trying to do many things here. It's a bit expensive, but the costs are going down now. But yes, so I remember, I think this was like 2 months ago when coming out like this mass, sometimes with an ulcer. And you need to go and find out the difference between a benign ulcer and a malignancies of the two. Okay, yeah. So this is a tumor like this. So for the diffuse part, diffuse type, it doesn't form these masses like this. It spreads across like this. So what you're seeing in this photo, okay, which makes the wall of the stomach to be so thick. You're seeing here, it spreads like this, or plastic leather bottle stomach here, leather bottle stomach. It looks like this, like a leather bottle. You see, this is a bottle, okay, because it's the way it's infiltrating. So that's what we call it for the diffuse type. Okay, the other one is those polypoid exophytic lesions. This one, I show you gross. So you look at the lower parts first. So this is our stomach. You can see the rugae like this, but this is the tumor. You can see the mass here. It's exophytic. It's coming outwards. And look at it under the microscope. It forms glands. You can see the glands here. This is normal mucosa. Then this is a tumor. You can see the glands here in the tumor glands. You can see this. And the cells lining these tumor glands are pleomorphic. They are abnormal. Okay, you see this area? Very different from this area. Okay, this is normal here. This is abnormal. As you can see, these are all abnormal. This is this intestinal type. Now we come here. I said leather bottle. Okay, because it's for the intestinal type, diffuse type. Sorry, it spreads like this, straight like this. So you can see how thickened this wall is. That's what gives you the leather bottle type feeling. Thick like that. It spreads like this. In fact, what happens? Most of you, they're afraid they might perforate, they're afraid, So they pinch very little and they miss the real thing. But then they tell you, I am very sure it is malignant. Then me on my side, I say, whatever you gave me, the small biopsies are not malignant. You need to go deeper. It becomes a fight. It becomes really a fight. We have fought many times with the gastros. We have fought. But sometimes they even force you to go sit with them and you see where they're coming from. Yeah, but yes. So anyway, that's how it looks. And then the cells are signaturing. This is a special stain, the immunoperoxidase stain. That's why you're seeing it brown and not like a HNE. But these are signaturings. They're usually like that. They form a circle like this. It's like a ring. A ring when you're giving your girl a ring with we call it a pendant. We call it what? Yeah, that thing on the top. So the nucleus is that thing on top pushed, the pendant. So this is space, and then here, ring, signet ring. I should have better photos for signet ring. I think I didn't put for you. I'm sorry. Yeah, I didn't. But yeah, I wanted to compare the two. Okay. So here is the endoscopy showing you the tumor. So here we are. She has gone in. And what does she pick? Here is a tumor. Surgery. This is gastrectomy that has been done. This is not partial. This is full. Because you're seeing this, if you went up here, I think, no, it's not total. I think it's total. I think this part has been cut out. This one is partial. Okay, half of the stomach is still left in the person. Okay, so because they picked something like this, here's a tumor. You can see with an ulceration here in between like that. Okay, yeah. Here is a tumor. This one is for the one which is infiltrating on the wall, which we've called diffuse. So you see the rugae nicely here, but here you don't see it nicely like that. So this is where they tell you, I am very sure we're having linitis plastica. Then they pinch just superficial. Then I look and I can't see the signet rings. I can't see tumor. Then we fight. They're like, you're the one to call back that patient to repeat. I'm like, no, me, I give you what I found, but I'm willing to analyze again for free. For example, just call the patient, let's repeat. It's really bad, but we didn't see it. It's because it's very tough like that. Okay. And then this is tumor in a stomach gastrectomy. It has been removed. Here's a tumor nicely. This rugae like that, and this is the tumor, all this like this. Good. So diagnosis. Again, red flags. Dyspepsia. Dysphagia. You see, especially at the cardia, they'll say early satiety, nimeshiba haraka, you know all that. Obstruction, especially if it's at the pylorus. Now the end, stomach. Here. If it's here, they get early satiety, they may have dysphagia if it's up here. If it's here near the pylorus, they can, this mass, if it's here and blocking, they can have obstruction. Okay? That's what we mean by sight. So they have symptoms of obstruction, vomiting, postprandial, you know, all that. And they may even have the one that is projectile, inaruka, you know. Unexplained weight loss, very important. Iron deficiency anemia, very important. Persistent vomiting, important. Sometimes a palpable epigastric mass. It's rare, but especially for the pyloric ones here, looking at this area, you may palpate a mass. Okay, like when you see babies with pyloric stenosis. You know, pyloric stenosis, there's that one for acquired, there's the one for congenital for children, and then there's an acquired one. And one of these, like tumor, can cause an acquired form of pyloric stenosis. Yeah. Yeah. Then that's physical, what they present, clinical manifestation. Investigations, gold standard. I repeat again, endoscopy with biopsy. And we have seen. Then the others are just for staging. Okay. Yeah. I had two again for guided therapy. General management, early cancer, you can do resection endoscopically, especially for T1. Okay. Surgical gastrectomy, either partial gastrectomy or total. I've shown you photos of those. When you remove the whole stomach. Again, as I said, because you could ask me, you can come in. Partial means this is the stomach like this. The tumor is like this one, the way it is. You can come in and cut here, that, and here like this. Then you take this edge that you have not cut here and join it with here. So you've done partial gastrectomy with anastomosis. So you've joined the proximal part to the duodenum. Then you've removed this part. Okay. Yeah, so you can do that. That's partial. But you can also do total gastrectomy, meaning you come in here, you cut at the esophagus and at the duodenum. You remove this whole stomach. Then you'll do now anastomosis, where you bring the esophagus and join it to the stomach, to the duodenum. Okay. Yeah. This is surgical. Then locally advanced disease, you give chemo. Okay. Before that surgery, you do chemotherapy, and then after that, you can decide, depending on your center. After chemo, neoadjuvant chemo, then you can go and do gastrectomy. For metastatic advanced disease, you now do systemic chemotherapy. You can try targeted therapy, you know, yeah, and immunotherapy, you know, after you've done these tests. Yeah, that's what I was telling you. Sometimes they're asking us for PDL1 and MSI, microsatellite. Then they can see whether if they're positive, they can give some immunotherapy. As usual, palliation. Palliation for all tumors is very important. Palliation. So that's why we are treating, when we talk about tumors, we usually have MDTs, multidisciplinary teams, which meet. By the way, nowadays, every day there's a multidisciplinary team meeting. So I remember Wednesdays is surgical, Fridays is neuro, and urology. I think, is it Tuesday urology? I might still on Friday. So they're all those running, and they're running for different hospitals. So sometimes you might hear your case is being discussed in Nairobi hospital, so you have to present it. Kenyatta, it's always been presented. I like Kenyatta because I give the registrars or the residents my cases and they present me. I'll just be there in the background. Yeah, so they are always being presented. Okay, from wherever, you know, if your patient now you send to KOTRH, you'll be discussing with the members as they're discussing that case. So that's, and so that everybody contributes to the management of the patient. Yes, and I'm now almost done. I have the last part, colorectal, which will take us maybe 10 minutes, the way I've been doing with the others. Again, colorectal has become so common nowadays. There's an MP who also died of colorectal. Remember the one for Kibra? Okoth, very nice MP. And there's somebody else who died of colorectal prominence. I can't remember. But colorectal tumors are also very common. I had one on Monday, resection. We had already done diagnosis maybe a month ago, and now because it was causing obstruction, we have done it as resection. Yeah. So colorectal, I can say, is common also. These GIT ones, I see them a lot. So risk factors and etiology, diet, low fiber, high processed foods, etc. I think the low fiber, meaning that I could give an explanation a bit of low fiber, is that you see now when you have low fiber, you're not forming stool and discharging it. So you're having fecal contents remaining in the GIT, in the colon. Okay, because when you eat a lot of those raffages, those fibers, they make you go for a long call many times. So you're really emptying your colon. But now when you don't have those raffages, the fiber is low, you have now fecal matter staying longer in your GIT, and so it now causes inflammation and changes in the wall of the GIT, which can be one of the hypothesis that we can use for diet. Of course, with genetically susceptible individuals. In activity, alcohol and smoking, we mention it everywhere. Western diet and metabolic syndrome, these are related because they'll have processed foods and low fiber. Okay. Medical conditions, as we said, the inflammatory bowel disease, which you already mentioned, and then previous colorectal polyps. We'll talk about polyps briefly. Genetics, very important. You can see they have put very many things on it. Family history of colorectal puts you at a very high risk. Mutations like the APC gene, okay, especially in familial adenomatous polyposis, very important risk factor. Near 100% life risk of developing when you have this FAP. Then Lynch syndrome, where you have the non-polyposis colorectal carcinoma. Okay, this one, the gene involved is the mismatch genes, DNA mismatch genes, which we'll talk about briefly. Okay, then you have other syndromes. Okay, then age, it rises steeply after 50 years of age. Okay, but I have seen younger ones. I think my youngest was, that young man, we have even sent him to be checked because he has a strong family history. I think the uncle died, the father died, the mother had died, the grandmother, all those related to this. It's just a strong, this was, I think, 4 months ago. It was early this year. Was it in April or thereabout? This young man, he knew, the way they know. Anyway, I meet with those people a lot nowadays. And family history, they come early for screening or for us to do colonoscopy. Yeah, anyway. Yeah, these ones I have seen quite a number. So we start, let me remind you what polyps were. And then so that when we mention them, you're in the same above the mucosa. This one, okay. It could be pedunculated, okay, have a stalk like this one has a stalk, or just serrated, sessile. Then polyps may be formed as a result of, very important, abnormal mucosal maturation, inflammation, and forming change in the architecture of the mucosa. These polyps that are because of inflammation and that are called non-neoplastic, and many times they do not have any malignant potential. Okay. On the other hand, there are those polyps that will arise because of epithelial proliferation. Mark you, I said that one was abnormal inflammation and maturation. Now here I'm saying epithelial proliferation, exaggerated proliferation and dysplasia. We call those adenomatous polyps or just adenomas. And these ones are the true neoplastic lesions. They are precursors for cancer. Okay, that's the only reason I brought this up. Here I'm just showing you gross. These are polyps. You see there are many two polyps here. Okay. And then this is histology of those polyps. If you take this is how it will appear. Okay. Above the mucosa. So screening of these colorectal polyps, when for the neoplastic ones we've already mentioned, they could be single or multiple. When they're multiple, we say polyposis, like that familial adenomatous polyposis. So here single, we have adenoma, tubular, tubulovillous, or villous. When there are many, we call them familial adenomatous polyposis, FAP. FAP. Hematomatous are just those juvenile ones which are not malignant. They are more of like this Peutz-Jeghers syndrome is associated with progressing to cancer, okay? Especially when they are multiple. Then inflammatory ones are benign, lymphoid, okay? Yeah. So of importance, of course, is I wanted you to pick these different types of adenomas that we can have, which are neoplastic, okay? We will not go into many details about them because they lead to carcinoma, which is what we need. So you are just grouping them, okay? I show you photos. Here they are. This is a nice adenoma here, okay? So that the different subtypes. This is villus, adenovillus, tubulovillus. You see it forms like tubes, long sticks, okay? These are tubulovillus adenoma. Usually I'm very careful when I see that, and it's just been brought in as a, like this polyp that has been removed, a polyp removed. Then when I see this one is just a tubular adenoma. When I see it as this one, villus like this, I tell the surgeon, you need to go back and make sure even all edges are taken out, and that you have to keep on doing follow-up on that patient, because they can easily become malignant, whatever else that grows in that patient, because you know that this patient is susceptible. So usually there are guidelines of how they monitor them. Yeah? You'll go and check them out. There are different guidelines. Even locally in our country, we have guidelines. Okay. So classification, again, as I said, by behavior, benign and malignant. So benign, we've looked at the adenomatous polyps. So we have the tubular, then villus and the tubulovillus. Then serrated polyps, which are mainly hyperplastic polyps, what we used to call traditional serrated adenomas. Then the hematomatous that we have already seen. Malignant. What is very important for today, which we'll discuss, is the adenocarcinoma, which forms again 95%. Then just like in the stomach, there are these other ones that are there. They're rare. I'll not say 100% rare because I made a diagnosis 1 week, the month of September, for someone with a neuroendocrine tumor at the cecal area, at the valve. Again, I sat down with my gastro and she explained to me that, they're common around there, etc., etc. Yeah, because I was stressed about it. I mean, I just looked and I'm like, what is this? And it was a functional neuroendocrine tumor. Functional means it was producing serotonin and all those things, VIP, all those, it was producing them. Anyway, anatomically, the colorectal adenocarcinoma, we can have them in the right colon, which is the proximal part. And these ones are mainly associated with microsatellite instability, okay? And they're mainly mucinous adenocarcinomas. Then the ones on the left, okay, going all the way down to the rectum, or the distal part, the lower part, most times they are obstructive and circumferential around them. We'll discuss them again, okay? So we go to pathogenesis, okay? Pathogenesis. So for the adenoma, it's just that same sequence. Adenoma then becomes carcinoma, and then it's a classical pathway, which I'll explain in a few minutes, okay? There are two pathways, which I'll explain in 2 minutes, okay, for how they develop. So we have a normal mucosa, then comes adenoma, and it's because of mutations in the APC gene, okay? Then mutation in the KRAS, and then mutation in the tumor suppressor gene P53, okay? They're usually more left-sided, okay? Okay, proximal, okay? Distal, sorry, left is distal. Then serrated pathway forms about 20 to 30%. The serrated sessile ones, they're more on the right side, and their mutations more of BRAF and others that I'll talk about, because they cause mismatched DNA sequencing. I'll explain. There are two pathways for colorectal, which I'll explain, which is this and this. The other one is just those parts of inflammation, like because of ulcerative colitis that we give, okay, which may lead to dysplasia then carcinoma, okay. So I need you to mark the two pathways, pathway 1, and pathway 2, okay, which I'll talk about in 2 minutes. Maybe I skip this so that I show you the pathways nicely. Just I repeat, here is a pathway. So the molecular events that lead to colorectal adeno. Remember, 95% is adenocarcinoma. Okay, so these genetic abnormalities, the APC gene mutation, and what you have to remember is that your APC gene usually acts on beta-catenin pathway. Okay, so this beta-catenin pathway makes you to now moves to the, because now there's excess production, it goes to the nucleus and causes proliferation of cells uncontrolled. Okay, yeah, so this activated in the classic adenoma sequence, okay, the APC gene. Then the other one is the MSI pathway. MSI is microsatellite instability. So in this one, the repair genes that we usually have for DNA, there's a mismatch in that. So you'll end up having several sequences. You see the way DNA is amplified or is duplicated. So you usually had those proteins, like, is it A to T, then C to G, like that. Now, because you end up having a mismatch. So instead of doing A to T, you end up doing like T to G, like that. And then it's repeated, okay? It's a repeated thing. So you accumulate those abnormal genomes leading to abnormal proliferation. That's the pathway, okay? That's the pathway, okay? Then on top of now, with all this happening, you can have other epigenetic abnormalities, gene silencing, so you're not able to even correct these mistakes, then and therefore this progression of the disease further. So these main pathways are very important to 80. And there's, as I said, there's the APC mutation affecting your B-catenin, then leads to KRAS mutation. Again, KRAS, when you have mutation of the KRAS, loss of apoptosis, you'll not be able to kill the abnormal cells because you've lost the tumor suppressor gene also, P53, okay? The one for the MSI pathway is because of mismatch, okay? So you'll have even the BRAF mutation in that one. Again, it's a lot of molecular, which is what I was talking about here, okay? Yeah. Okay. So it's just to show you what I said about that pathway for the APC. Okay, so you have a normal colon here, but you have inherited a germline or a somatic, you've acquired an acquired some. Then additional methylation, abnormalities occurring, you're exposed to other things. So APC to actively now work on your beta-catenin, okay? Because now all the normal alleles that had been left, there's the first one that had you inherited or caught the first time. Then the second one, you get now other methylations. These ones I was talking about, additional, okay? Then now, either because of the food impaction, etc. So with that now, you have the proto-oncogenes, KRAS being activated. So you end up having now all this abnormal cell proliferation, okay? Then there are more things that can be added onto that. You have your SMAD 1, SMAD 2, SMAD 4, like that. They're called like that. Okay. Then additional mutations. First, you form the adenomas. When you add these additional mutations, changes in your telomerase and other genes, because telomerase in tumors, it adds, the enzyme works. So you end up having, instead of aging, the way we say it now, it goes back. I think we mentioned that in general pathology. So you end up having your carcinoma like that. Okay, that pathway. Then the other pathway that I said is the MSI pathway. So you have, of course, the inherited or somatic acquired mismatch gene for the DNA repair. Commonest is your MLH1 and MSH2, yes. There's MSH1, 2, MSH2, MSH3, MSH4, but the commonest that we've been able to pick is MLH1 and MSH2. These are the others that can be there that are mutated now, okay? Then altered second allele in that place with the methylation, now you start having changes, mucosa, which is at risk. Then if you get now many of those sequences going on, which are mismatched. We are not being able to repair. They're going through the cell cycle and we're not being able to change. Then you have now accumulation of cells that have already been damaged and not being able to repair. That is the microsatellite instability, and we call that a mutator phenotype, which has already occurred. So you come, accumulated ones, other additional ones come in, your bugs, your BRAF. So they make you to have uncontrolled cell cycle, okay? Mitosis. Because you see, remember, like bugs is useful in apoptosis. Now it is mutated. So you'll not kill the abnormal cells. So they just keep on forming. And so you have a mass. You see the mass is forming here nicely. Serrated adenoma. Additional of this becomes now invasive. It moves from the mucosa and now invades into the submucosa up to the muscle. That's how it goes. So now what we are doing in genetics, in molecular precision medicine, we are going and picking, do we have a KRAS mutating this one? That way we are able to tell now how to give treatment. And that's the molecular basis. I have really summarized it. The best I could do. Histology. Adenocarcinomas, I've already said there, gland forming, sometimes mucinous, like the one I reported on Monday was a mucinous one. Adenomas, we have already talked about the different types. Neuroendocrine, not as common, but we see it. It's the same as what we saw salt and pepper in the lung. Okay, so I leave it that. So morphology. So for the left-sided cancers or tumors, they are annular and they fill the, sometimes obstruct the lumen, okay? For the right-sided one, they're exophatic, they're polypoid. And so the way the patient presents is with bleeding. And most times it's occult bleeding, meaning you don't see the blood, frankly, in the stool. Okay, so we do tests, the FIT tests, fecal immunohistochemical test to check whether there's any form of bleeding. But they many times present with iron deficiency anemia. So you're able to pick. That's why I'm always saying, find out the cause. If you have an iron deficiency anemia, find the cause, okay? Adenomas we've discussed, so there's nothing much there. This is microscopy, how we see them. I've already mentioned about it. So we go to the pictures, very nice pictures. So here we have a patient who has familial adenomatous polyposis. So that's why you're seeing so many polyps here. You're seeing these two polyps. That's what the patient has. Okay, this is it. Sorry, just a minute. I'm seeing Faith wants to talk to me. Sorry. Oh, Faith says you have a class at 11. So I'm just about to end the class. I'm just showing the photos. So Faith, just look at the photos. I'm finishing, eh? The photos. I'm just showing photos. I finished the class actually. So just showing the polyps, the many polyps, then the tumor. This is the tumor here. Okay. In a patient who had polyposis. This is the tumor. The white thing that you're seeing is a tumor. Okay. Again, another tumor. This is the wall. Okay. This is the wall of the gut. All this is tumor infiltrating all the way. This white thing you're seeing, all this white thing. Then this is a lymph node, which has tumor. Okay, so you can see this is fat. This is the mesenteric or the fat around the gut. Okay. Another one is tumor with here, like this. Okay. Then when you take this and look under the microscope, this is what you see. They usually have what we call desmoplastic reaction, like this. Then they have tumor necrosis, dirty necrosis inside, like this. Okay, that's tumor. And I have finished. This you'll go read. It is just a summary. Okay, and take photos. Just a summary of saying the type of tumor, obstruction, the mass effect, then clinical presentation of the patient. Okay. So diagnosis is my second last slide. Red flags, rectal bleeding. Especially that's why we say, look at your stool all the time. Change in bowel habits, especially more than 6 weeks, lose more frequent stools. Iron deficiency, unexplained weight loss. They may have an abdominal mass with persistent pain. You need to look at that. And then you do stool for occult blood, the FIT test, and find positive. suspect colorectal cancer. Family history, very important. So investigations, we always do a fit test for screening and triage. If the fit test is positive, we do colonoscopy, okay, which is the gold standard. Colonoscopy and biopsy. That's a take-home message for today, okay? Yeah. Then CT scan, ETC, all the others are for staging. We do tumor marker CEA for monitoring and diagnosis, as I had said earlier. General management, here we are. Precancerous polyps, you remove them endoscopically. Okay. Then you do surveillance. The same I said, you have to go and check the guidelines. Even in Kenya, we have guidelines or how you do surveillance of those polyps. Okay. Just read the guidelines. Okay. You'll see them online. For localized cancer, you can do surgery. Okay. Many times we do hemicolectomy. Like now, the one I had was a hemicolectomy because it was blocking. There's obstruction. Then locally advanced cancers, you give neo and chemotherapy. Metastatic, you just do chemotherapy. You can't operate. And you do targeted treatment. These are different methods of targeted treatment. And that's the end. Palliation, I have said for everyone. Okay. So I see some of you have already slept. Others have gone. And here we are. We have finished.
Comment on hemorrhoids.
Sorry?
Comment on hemorrhoids. Are hemorrhoids just like polyps could predispose to colon cancer? What about hemorrhoids? Are they related?
No.
Patients where managed.
No. Hemorrhoids are not. Hemorrhoids, I'll teach you. Is it me or who is teaching liver cirrhosis? Either Dr. Obiero or myself. We will talk about hemorrhoids. Those are just systemic portal blood moving together like that. Now at the anal region, it is not related at all. Piles, which we call hemorrhoids, is not related.
Thank you.
Is not related to this. We'll discuss that a bit in hemorrhoids. And what you see in hemorrhoids, you just see thrombosed blood vessels. Yeah. And sometimes they may, depending, the different stages or levels of hemorrhoids. So if it's more with prolapse, then you may have, because of constant irritation on the anal mucosa, you may have now changes, which can be squamous cell carcinoma, but hardly. But we look for that too in hemorrhoids, yes, which is very different from this colorectal that I'm talking about. Even in pathogenesis, etc., hemorrhoids are not the same as this. They are not even risks for colorectal. They're very different. Another question? But I'm sure you've seen patients with the way Julius, now you have seen for your patient. We've mentioned many things for your patient.
Yes. I've seen. But I think the other challenge we have is the flow chart. I think like even Nyahururu level 4, there's a patient who I think they did endoscopy, had a adenocarcinoma, and but the oncologist, when they did a biopsy, the result showed that actually had adenocarcinoma, but they refused, declined to say that being moved from one doctor to the other. By the time the doctors agreed that the patient has adenocarcinoma, the patient had just now, it was actually diagnosed. It reached 4th stage, and now the patient just died. So again, in our hospitals, we really have. I don't know. There's no a good flow chart where you know where to refer who from where, and so we really keep on waiting. And then also, as we keep on waiting, there is the malignancy increases, it actually grows. And I think this is really also contributing to how we are losing our patient to some of these tumors.
I agree with you fully. We from Nyahururu is the same as that patient I told you that I saw 1 month ago who had been seen in April. Imagine from April till now, they had not done the right diagnosis. I think what I can say at the moment, what I have noticed is that people are not clacking patients. You're not taking history from patients. That's number one. And by so doing, people are just sending them for imaging, go do an ultrasound, go do, I don't know, CT scan, go like that. And then they do blood tests without talking to the patient. Because if you read even Hutchison's, it tells you that by clacking and examining that patient, you'll have like almost 70 to 80% of an impression of where the disease is. So you'll do targeted imaging or radiation or pathology, tests. I think that's one part we are losing on. Another part is, as you said, the referral mechanism. And I'm happy because you've mentioned Nyahururu. And the day that I was not available for your class, there's something we are doing with the National Cancer Control Program. I sit there a lot with them. I am in one of the pillars. So we've been trying to go to the counties and establishing different things. So for the whole week, I was in Nyandarua County, where Nyahururu falls in. And in fact, in that county, the JM Karaoke is the main referral hospital. So we sat with it and did, one of the things was even the referral. So we went through, we're trying to establish diagnosis. And what we notice is that for them, when they do like the endoscopy, or whether privately or publicly, they tend to Aga Khan. There's a spot in Nyahururu where they send the biopsies, then they're sent to Aga Khan. Of course, the TAT is not, these are follow, then now we taught them about follow-up. When the patient comes back, what do you do? And is it everybody that you're sending there? How much? What are the costs? We had to establish all those so that we can see how we can have a central region where the tests are done. Establish one now in that county. So that is what we are working on. And I understand it's not
very helpful.
Yeah, we're doing
that.
That.
Would be very helpful. Yeah, very nice. It would be very helpful.
Yeah, so that's a project we are working on. Yeah, and I understand where you're coming from. Like when I tell you on my desk what I see, I nowadays I spend time. You can see even my lecture, I have put red flags. I'm not making it different from what I had done before, because I feel we are losing out. But if I gave it to you today, by the time you're finishing and you're practicing, you'll remember that and know what are the red flags. When do I send the patient to where? What is, you refer. And we stop being money-minded, because, you just keep on taking dressing. It came at stage 1, now it will be stage 3 by the time you get diagnosis, So also there's a human part from us also, Julius. And as I said, we have MDTs. So you see, like, now that I told him, for me, the gastro says, I saw it, you come, I show you. But now you see, if we usually actually just repeat. We repeat the biopsies. For us, gastric biopsies, you have results in 3 to 4 days. When she was doing the biopsy, then now we move. You have a diagnosis, and you're already sending to the to the oncologist. Yeah. We have a system. But again, the one I'm talking about is a bit private, not as public. We try to relate the same thing in public, but you know what happens in public. But yes, yeah. Any other queries? You can spare them even for the next class. We can still talk about them, because the next one will be short. It's not as long as today. Today I was discussing too many things. I didn't even know how Prof used to manage teaching people all this. I'm sitting in for her. Yeah. Okay. So thank you very much. Enjoy your morning. We're still in the mid-morning. If there are any queries, please spare them. We can discuss them even next week. I have a class with you. Go ahead, Julius. Okay, you too. If there are any queries, you can ask. Next week, I have a class with you again.